right, you're good.
Okay, for the high flow, obviously this one's not hooked up to oxygen right now, so you don't see readouts. If it were hooked up, you would see your FiO2 readout on the screen right here. This is gonna be the flow that's set, just like a regular flow meter, so wherever the ball is, that's what it would be reading. So if your patient's on 40%, your 40% readout would be right here. Your 30 liters, if they were on 30 liters, it would be over here. The little knobs on the side, your top knob is gonna adjust the FiO2, the bottom knob is gonna adjust the flow. So if you have a patient that is desatting, you would wanna go up on your FiO2, and if they are short of breath, you would go up on the flow. However, anytime that you go up on your flow, you're gonna have to adjust the FiO2 a little bit, just because it drops your FiO2. And anytime you have to make adjustments to this, make sure that you call the RT. We would like the RT to be able to do that, but if they're not readily available, we need the patient to go up on the FiO2 before the RT gets there. This portion of it is just gonna be the heater. The readout that's gonna be on here is just gonna be the temperature. You don't really have to document anything with that. It's just for the RT's knowledge to document. If it has alarms on here, if it's alarming, it's usually two different problems. Either the water bag is empty or your temperature probe has an issue. A lot of times, if you have a patient that has a fan blowing on them, it'll cause this to alarm because it thinks it's not as hot as it really is. Or if the patient's getting medication, sometimes this will get like crystallized medication on it, and it can cause it not to read accurately. There are 3 different sizes for your cannula. This is gonna be the small, it's orange. There's also the medium, which is probably the most common size. It has the blue on here. And then the large is green, which we don't see these very often. And then anytime your patient's on 50% or greater FiO2, we need to make sure that the physician is aware that they're on 50%. That doesn't mean that they can't be up on the floors. It just means the doctor has to be aware that, hey, this patient's requiring this much oxygen.
Is there a limit to being on the floor with?
There is not a limit in the policy that's written. However, I feel like it kind of depends on what's going on with your patient. COVID changed a lot of that, where we had people that were maxed out up on the floors. But yeah, you just make sure the doctor is aware.
So, sorry, short of breath, oxygen? No.
Short of breath, flow.
Flow.
Desatting, you're gonna go
Desatting,
oxygen.
Oxygen, okay.
Yep.
Got it.
And then for trachs, at the bedside of every trach patient, you should have one of these little buckets. In the bucket, you're gonna have your spare trachs. So if it's a size 8 trach, you're gonna typically have a 4, 6, and an 8. If it's not a perk trach, or if it's a patient that's had their trach for a while, you would only have to have the size that their trach is. So if they had a 6, you would have a 6, and then a size smaller. You also want to make sure that you have extra suction catheters at the bedside. There's also going to be trach ties in here, and then some extra inner cannulas just in case you need one. Emergency equipment, this is going to be at the head of the bed with one of these trach signs. You're going to have an obturator in here and the syringe. Your syringe is pretty much only going to be used if you have to inflate the cuff on your trach. If you needed to ventilate the patient, or if the patient was vomiting and you wanted to make sure they're not going to aspirate, you could always go inflate the cuff. Trach sign. This is just basic information so that anybody could quickly look at this to see like what this trach is. It'll have your airway type, the size, whether or not it's a perk trach, which the perk trach is just the way that it's inserted. So it's going to be inserted at the bedside. Typically, they just dilate until they can get the trach in rather than making a surgical incision. So it's going to be a tighter stoma around that trach. If it were to come out, it's really important to get it back in because that could close quicker. And then it also has the suction size that you would use when the trach was placed, and then all of your emergency equipment that you would have at the bedside. The only
Sorry, I just know a lot of people have asked on the unit, like how to use the arbitrator. Is that, so if it pops out, you're putting that in the cannula and then pushing it in?
You would take the inner cannula out. You would have, the obturator goes just right in there. And this basically makes this have a smooth tip to make it easily inserted back in there instead of damaging your airway. And then once the trach is back in, you would just take this back out and put your inner cannula back in.
Cool, thank you.
It just clips right back into place. And then if you're not familiar with this, your little pilot balloon on here, that's how you can tell that this is a cuffed trach. It has a pilot balloon. Whenever you inflate this with air from your syringe, this cuff would inflate. On the back side of this airway sign is going to be a dislodgement algorithm. It has the steps that you would take if your trach were to become dislodged. The most important thing is you're not looking at this whenever this is happening. So just be familiar with this, know it's there. This is in the policy. If your patient is desatting, if they're in distress, if you're not able to ventilate that patient, you're gonna call a code blue because we wanna make sure that we get that airway fixed as soon as possible. As far as trach care, this is done.
Excuse me, but if accidentally gets off, do we have to put immediately the same cannula back in?
That's why your spare trachs are gonna be at the bedside. So if you're able to, you
but then
can
why
put
do we have to put the
the obturator.
obturator?
These kits are gonna come with one.
I
So
know, but
anytime
then-
you're having to reinsert it, you would put the obturator in this trach. So if you're able to, you're gonna wanna grab a clean trach because you want it to be as clean as possible. If that trach was on the floor, obviously you don't wanna put a dirty trach that was on the floor back in the patient. So you would get your spare trach, open it up, put the obturator in there.
Okay, so the one that we put in the wall really
Why would you
doesn't
not
have
just
a
put a
use?
new cannula in?
If it's just the inner cannula that comes out, you can just replace the inner cannula.
Right.
If it's the entire trach that comes out though, you're gonna use a whole new trach.
Right.
Yeah.
So the spare in the wall doesn't really have a use, the
The-
obturator.
The obturator that's on the wall.
Yeah.
So if your trach comes out and you're trying to just like keep this open, you could also put the obturator in there just to keep the trach, like your stoma open. And then you
So
can get
just
everything
directly
here.
Put in the.
Okay.
Yeah.
Okay, that's good to know.
Trach care,
That
you're
was
just
not-
gonna do
that's
this.
what I'm not clear of.
Trach care is gonna be done once a shift, and then as needed also. This is a nursing responsibility. However, you have to do an RTR and skin check with all of these trach patients, so it's a great opportunity to have the RT do trach care with you as you're in there. You're just gonna use your little Q-tips, your normal saline, clean underneath the trach, under the flange, around the stoma, make sure that it's nice and pretty and intact, and then change out your dressing that is on your trach as well. Whenever you're doing the RTR and skin check, you wanna make sure that you're looking behind the trach ties as well. We've had a lot of patients that had breakdown behind their ties. I think that's it, unless you have questions.
Nope, thanks.